friends. So today it's going to be a class on pain physiology in brief, and as we learn through the physiology of pain, we'll also learn about, in short, about the analgesic drug action targets. I mean to say where drugs act when we think of analgesic and pain modulation. So that's the class all about. So it's going to be a starting session of pain clinic. We will be having a total of 3 sessions. The next session is more on particular drugs, analgesic drugs, and then the last session is going to be more of a case-based learning session in which we'll try to prescribe drugs for various cases of pain. So starting with this topic of pain, let's try to define pain. I mean, everybody has experienced pain in our life at least some time, and we know how unpleasant it is. So pain is a kind of unpleasant sensory. Of course, it's a sensory thing. It's not something motor. It's sensory. It's sensation. It's kind of unpleasant sensation, which is also associated with emotions. We try to cry when we get kind of a pain. So these are emotions attached to pain, because simply it's not something which is a feel good factor, and it might be associated with actual, or it might be associated with potential tissue damage. It's kind of an alarming signal most of the times. So some people say that pain is also a kind of a vital sign. Anyway, there are a lot of debates on whether we should accept that term or not. But whatever it might be, pain is something which is sensory in origin, which has an emotional component, and which is not something which is feel good, and may be associated with either actual damage. There can be a fracture of a bone, there can be a tissue damage, or it can be something which is upcoming. The damage might not be full-fledged. The damage, it's kind of giving you signals that, hey, listen, the damage to the tissue can occur if you continue onto this path. So that's the way we describe pain. Of course, it's very important. Please, as individuals who practice medicine, we need to understand that. We need to, look at pain seriously. Sometimes you often say that it's kind of a mild pain, so let the patient bear it, or something, some kind of it. But then actually it's very distressing. Even mild pain for a very long time can be something which can affect the mood of an individual, can affect the life of an individual. So pain is something that we all should be taking very seriously when it comes to clinics. Anyway, so pain has some kind of a sensory component. Yes, pain has a sensory component, a peripheral component, from where the pain arises. For example, there can be a tissue damage, might be there is a wound, or there can be a fracture, there can be burn in part of a body. So that's the sensation from where the pain arises. And then we have the sensory, the central component. That's the perception component. That's how we perceive pain as. I have been practicing for some time in tribal areas, and I've seen people who are tolerant to pain. It's not that the pain is less, but they have developed over generations. They have developed this ability to tackle pain in appropriate way. They can bear pain more than what the urban individuals can do it. But anyway, that's my observation. So there's a central component of perception that also needs to be understood. Sometimes we often try to neglect pain, but at other times we might take pain seriously and rush to a doctor for some consultation. So that's the perception of pain that changes from person to person, or even in an individual, it can change from time to time. So pain, as defined, it's very subjective. A person suffering from pain, it's something which he or she experiences. So I may not be the right person to say whether the pain is very high, or whether the pain is mild or moderate. No, it's up to the individual to say what the pain feels like, Okay, it's also a protective kind of a mechanism, because it tells us that okay, something is wrong here and you need to attend to whatever the damage has occurred. It's as I told to you, example of tribal indies. So it modified by developmental behavior, personal and cultural factors. You often see individuals in army or somewhere where they are trained very well. The training component also has a part where they need to tackle pain adequately. It's not that the pain is less, but how you perceive pain, how you react to pain is different from the rest of the civilians when it comes to the army individuals. It's also a symptom. So I said to you, you need to look at it in a serious way once you are a practicing clinician. It is associated with a lot of emotional outbursts and a lot of signs. So increased sympathetic activity, anxiety leads to sweating, tachycardia, mild increase in blood pressure. Now that depends upon whether there is blood loss or not, or whatever factors. So that will increase or remain same or might decrease. Anyway, if there is anxiety, it should increase on one side, and there are behavior changes. Some people might have a lot of anxiety. Chronic pain individuals might go into depression at the same time. So that's the emotional component and associated with the pain. There are a lot of types of pain. Anyway, whatever it might be, for a layman, pain is a pain, whether it comes from the deep or the periphery. But as a doctor, you should be knowing that as treatment goes, we need to identify types of pain. So it can be a very superficial or cutaneous pain, kind of knife cut, or might be a burn, a superficial burn, a first degree burn or something of that sort. Or the pain can be from deep muscles, joints, ligaments, bones, kind of fracture, osteoarthritis, rheumatoid arthritis, a lot of other kinds of autoimmune diseases, ligament tears, ligament injury, muscle sprain, pull. So it's a deep pain. Then it can be visceral pain, so something which is related to organs, hollow organs especially. So intestinal spasms can give rise to pain. A lot of inflammation inside the body, in the organs, can give rise to pain. Ischemia, ischemias of various organs. We always talk in terms of myocardial infarction, but then we also have cerebral ischemia, we have renal ischemias, and so on. So yes, pain arising due to ischemia, or it can be due to damage to the nerves, especially people who have a lot of symptoms, diseases like trigeminal neuralgias, and then herpes zoster infections which run along the nerves, gives rise to excruciating burning pain sensation. Pain associated with multiple sclerosis, which can be very vague in origin, fibromyalgia, which can give rise to neuropathic pain. So the damage to the nerve itself can give rise to pain. It can be psychological. Sometimes fabricated pains can have, people have a kind of attitude, kind of not disorder I should say, but then people sometimes tend to might fabricate pain in one way or the other. So yes, there can be a psychological element to the pain. A person might just have a pinprick, but then what he experiences and what he perceives and what he might tell to you might be a story of something of a fracture, a serious fracture, or might be a big wound somewhere on the body. So yes, perception to the pain, and then communicating the pain in the right manner to the other individuals also has a psychological origin. So always try to look through psychological angle before treating any kind of a pain. As far as nature of pain is concerned, then we have something called as fast pain. Now fast pain usually will be kind of a pain which relates to the myelinated nerve fibers, because myelin sheath is supposed to kind of transmit the impulses, very basics, and transmit impulses on a faster way. So pain which is acute in origin, which is more of a localized pain, which is of short duration, kind of fast pain fibers will be activated. So that's the A delta ones that are usually what we want to look at if we want to look at fast pain. Then we also have slow pain, which is more of a chronic in nature, long duration, which is which is poorly localized, vague pain, which is mostly due to unmyelinated nerve fibers, usually C pain fibers that we'll be talking of. As far as pain receptors are concerned, there are no special pain receptors. That's the one thing that you need to understand. Pain receptors are free nerve endings, which are also called as nociceptors, and they are distributed across the body, inside out, except for the brain as well as for the lung parenchyma. And any kind of injury or any kind of depolarization or stimulus to these nerve endings gives rise to pain in the body of the affected part. Nociceptors are very slow adapting fibers. That is very important for everybody to understand, and that's the reason that we can differentiate between fine touch, crude touch, and pain related touch, which can be deep sighted pain associated with skin. There are different types of nociceptors. Some nociceptors respond only to one kind of stimuli, might be hard stimulus. Some respond to maybe multiple stimulus, kind of polymodal in origin, whereas some only respond when there are inflammatory, kind of substances present in and around the nerve fibers. There are other nociceptors also, nociceptor-like receptors also, which can induce pain, and they are called as capsaicin receptors, and they respond usually to kind of heat or low pH, and stimulation of that gives rise to painful burning sensation in individuals. As far as pain modulation is concerned, as I said to you, there is a sensory component and there is a perception component. The central component deals with central nervous system mechanisms of how pain is perceived and modulated. So drugs, especially opioid or morphine-like drugs, act at the central system and try to change the perception of the individual towards the pain. So that's the classical pain pathway a physiologist might have explained to you, or you might have read it somewhere. So here it goes. You have a trauma to a limb, so there are the peripheral nociceptors which get activated, maybe due to release of cytokines, to example, and also due to the injury which is caused, and the impulse goes then to the spinal cord, the dorsal horn, and from there is a transmission of impulses along the spinothalamic tract, that's labeled in the red arrow here, and then goes up to the thalamus, where the pain is then perceived, and there is also a higher component of cerebrum which then kind of helps in action as well as or to react to the pain, also has that emotional component there coming up, and also helps to then modulate pain in one way or the other. Most of the studies have shown that we have descending modulation. When there is pain, there has to be modulation of that. Now, why we require this kind of a modulation? It's very simple. The reason is that sometimes we know that there is pain, but then we cannot stop for the pain, stop and can look at the pain. We need to just continue. For example, think of a general scenario where a person is being chased by a lion. Now when he runs, he starts getting pain, but he cannot stop for that pain and look around at his legs and wait for the lion to eat him up. No, we cannot do that. So sometimes we require this kind of a pain modulation where we know that there is pain, but we try to overcome the pain. So that's overcoming of the pain. So we modulate pain in one way or the other. So we try to bear the pain in one way or the other. So that's what is called as modulation of pain. And studies have now defined that there are these descending pathways which come from the higher centers in the CNS down to the dorsal horn of the spinal cord and cut down the impulses of the pain coming from the periphery. So that's in short about pain modulation. And opioid like drugs try to help and try to inhibit some kind of these kind of modulation, not modulation I should say, try to inhibit these pain pathways to bring about the changes, bring about their action of analgesia. So as I already informed to you, that evidence shows that the presence of descending pain modulation system is there. I told you why it is there. Anyway, as I told to you, there are endogenous pathways, descending modulating pathways. So some of the substances which are endogenously produced, which modulate these descending pathways and cut down the pain, are substances like endorphins, enkephalins and dynorphins. They usually act as spinal cord as well as act on the CNS. Some of them also have their action on the GIT. They have their special receptors which are called as opioid receptors. These are endogenous substances which mimic actions of morphine in medicine. Okay, so we have beta endorphins, that is an endogenous substance that was earliest to be discovered. It is present at the CNS. We have enkephalins, dynorphins, endomorphins and pronocyceptins. So these are few substances which modulate pain and which are endogenously produced, and they act via their own receptors. And morphine is something which is exogenous but takes help of those receptors to modulate pain in patients. So here is a kind of animation, it might help you. So here is a C fiber input, a slow fiber pain which is coming up, and this is the dorsal horn of the spinal cord, and this is the site where interaction of neurotransmitter takes place, and the pain passes on to the spinothalamic pathways. But you can see here that there is a descending inhibitory pathway, and this pathway, the blue pathway, especially modulates the pain impulses, cut down the pain impulses coming from the periphery, and does not allow them to go up to the spinothalamic tract. So if we want to look into more of what's happening at the cellular level, we have this green pathway, which is usually the pain pathway. This comes from the periphery, goes to the spinothalamic tract here from the circle here, and we have the substance P that helps in as a neurotransmitter there. And you have the enkephalins. I already explained to you these endogenous substances which are produced, which modulate or inhibit pain pathways. So this is produced, and this for example is the dorsal horn of the spinal cord where these interactions are coming up. So this is kind of a presynaptic inhibition of the pain impulses. So substance P helps in transmission, whereas enkephalins produced at the same time may try to inhibit the pain transmission. So if you want to look at animation here, we have those green dots which is substance P, and there is an impulse of pain which has come about. The release of P substance, and this P substances go and hit the circle, the receptors on the other side, and there is a pain transmission or a pain impulse that occurs usually. So that's the usual thing what happens. Now if there is a pain modulation which is coming up, we have this enkephalins, the blue ones, the blue squares, which you can see it on the screen, which is released at the time when the P substances is released, and then these enkephalins activate the receptors at the presynaptic junctions in the spinal cord, dorsal horn of the spinal cord, and they block the release of substance P. In short, they block the pain impulses totally. So that's how this usual system works when we talk about pain. A very simple animation which explains you pain modulation quite in details, and your morphine and morphine like drugs will be acting something of this sort when it comes to their mechanisms of action. So that's the very basic way of how morphine acts. So if that was a central component, a perception component, we have pain mechanisms even in the periphery of how pain is generated in the periphery. That is what we need to know, and then drugs which can help in reducing pain by modulating the pathways in the periphery. So if there is a trauma or infection, the top slide, there is cell membrane damage. Cell membrane contains phospholipid. Any damage to phospholipids or cell membrane gives rise to activation of enzyme called phospholipase, and that helps in formation of arachidonic acid, and that is further metabolized by two pathways. One is a cyclooxygenase pathway, very important pathway that gives rise to production of prostaglandins, and the other one is a lipooxygenase pathway that gives rise to production of leukotrienes. Production of leukotrienes and prostaglandins, activation of both these pathways helps in generation of pain. So that's the very classical pathway, the full pathway. So your phospholipids in the cell membrane, phospholipase A2 activated when there is an injury to the cell membrane, giving rise to arachidonic acid, which then gives rise to formation of prostaglandins. Very different kinds of prostaglandins which have different roles to play in the body, and this is the very important traction. Conversion of this acid to prostaglandin, and this is mediated by enzyme called as cyclooxygenase, or also called as COX enzyme. This COX enzyme occurs in two forms, COX1 and 2. Nowadays other forms of COX have also been identified, but anyway, keeping it very simple, it's just the COX enzyme. Whereas the other pathway is the lipooxygenase pathway, which helps in formation of leukotrienes. That's also inflammatory mediators, especially when we talk of bronchial asthma and so on. So you block this cyclooxygenase, you try to decrease the production of prostaglandins and help to reduce the pain in one way or the other. So by now you must have known, pain is not just a sensation, but it's more complex thing, and pain can be blocked at various stages. You can block pain at the periphery by blocking cyclooxygenase and production of prostaglandins, because prostaglandin is one of the important mediators for bringing about pain, inflammation, vasodilatation and so on. So block it by cyclooxygenase inhibition, by a few drugs like non-steroidal anti-inflammatory drugs, or try to modulate the pain at the central level, as we have seen with pain modulation, opioid receptors, morphine like substances and so on. So that's how pain is managed at the periphery and at the central component of the body. These are various prostaglandins that are produced, and each one has some or the other role to play. We have PGD2, which is most probably vasodilatation, which is also a component of inflammation. PGE2 is more to do with temperature regulation and GIT, mucus secretion, water electrolyte balances and so on. PGF2 alpha is a prostaglandin which is mostly concerned with uterine smooth muscle contraction. PGI2 is mostly related to vasodilatation and platelet aggregation. Thromboxane A2 or TXA2 is a substance which is a potent platelet aggregator and vasoconstrictor. In fact, we try to inhibit the production of thromboxane A2 by a non-steroidal anti-inflammatory drug, a low dose aspirin, which is then used as an anti-platelet agent. And on the other side, we have leukotrienes like LTC4, D4, which are more probably inflammatory markers which bring about a lot of increased capillary permeability, maybe chemotaxis, release of enzymes, destabilization of lysozymes, and then bronchoconstriction, giving rise to bronchial asthma. So this is in short about prostaglandins, thromboxane A2 and leukotrienes, which are produced by the pathway that we have just seen. But remember, this prostaglandins in total, their production can be inhibited, and in general the inflammation can be brought down by just blocking their production by inhibiting an enzyme called as cyclooxygenase or COX enzyme, which prevents the conversion of arachidonic acid to prostaglandins on a general pathway. These are a few other chemical mediators which also help in mediation of inflammation, and in one way or the other can affect pain. So we have PAF, that is which brings about vasodilatation, platelet aggregation, leukocyte infiltration, degranulation of leukocytes. Then we have histamine, which brings rise to contraction of venules, relaxation of arterioles, increased capillary permeability. We have bradykinin that stimulates pain receptors and it causes histamine release. We have serotonin that can give rise to pain, vascular response, especially vascular constriction, and then platelet aggregation, and a few others like lactic acid and calcineurin. Even though their role in inflammation might be less, but then do remember that these substances, in addition to prostaglandin, can bring about pain in the periphery as well as to extent in the central compartment, but more in the periphery. So just blocking synthesis of prostaglandin may not help to bring down the pain 100%, because these substances, if produced, they might still give rise to pain in one way or the other. So we say that analgesic drugs are not a foolproof treatment for pain. Very difficult to manage pain. And now that's the mechanism of action of non-steroidal anti-inflammatory drugs. Anyway, drugs which control pain in the periphery. Very simple. Non-steroidal anti-inflammatory drugs, drugs which inhibit pain in the periphery. So their basic action is inhibition of an enzyme called cyclooxygenase and reduction of prostaglandin biosynthesis. In addition to that, they will control the inflammation also at various stages. For example, reduce production of superoxides, induce apoptosis in cells, inhibit the expression of adhesion molecules that bring about chemotaxis of leukocytes, decrease nitric oxide synthesis, so decreasing vasodilatation, decrease pro-inflammatory cytokines like tumor necrotic factor, interleukin 1 and so on, modify lymphocytic action, alter cell membrane function, stabilize lysosomes. So these all things are what? These all things relate to bringing down inflammation in one way or the other. So that's the way that you decrease inflammation as well as you reduce the pain in an individual in the periphery. Now that's very important when you talk of non-steroidal anti-inflammatory drugs. When we talk of morphine, we talk in terms of opioid and central pain modulation, the descending pathways, enkephalins, endorphins, opioid receptors and so on. So two different drug sets, one action on the periphery, the other's action more at the central level for pain. Now as I said to you, the cyclooxygenase that we know of is available as cyclooxygenase 1 and 2 in the body, is two isoforms of the same enzymes. Cyclooxygenase 1, COX-1, is more physiological, so it helps as a normal functioning of the body, especially when it comes to stomach, secretion of mucus, gastroprotective, renoprotective in nature, managing or maintaining capillary permeability, maintaining the patency of the tubes, especially CVS, managing permeability to extent and so on. So that's where COX-1 is concerned with. When it comes to COX-2, it is more of a pathological in origin. So yes, so you better block two COX-2 enzymes so that you can bring down inflammation and pain. But then it gives rise to some other factors. So anyway, so the side effects, we have selective COX-2 inhibitors, but then we'll talk about them in the next chapter to come. But just for now, remember that COX-2 inhibition is more preferred because it is the one that gives rise to prostaglandins, especially when it comes to trauma, inflammation and so on, whereas COX-1 gives rise to production of prostaglandins, which are mostly of kind of housekeeping function for the body. Now that is all about pain physiology in general and about in broad sequence. I'm not talking anything very specific, in broad sequence of how drugs act in the periphery, the non-steroidal anti-inflammatory drugs, as well as how drugs act at the central compartment, morphine and related drugs. So I hope you like this session, and thank you for hitting the like button. Do subscribe, keep watching. Bye for now.